through the limbs before lunch. I'm confident. We'll see how well the brains hold up. All right. At least it's recorded. That's something. All right. I don't actually need this attached. Don't need this. Fit over here. Knees and elbows. To be honest with you, I tend to say if you concentrate on actions related to the ankle, actions related to the wrist, actions related to the hip, actions related to the shoulder, the elbows and knees are much happier. They're just hinge joints. So there's a limited level of function here, but they end up getting coupled in with the actions, especially in closed chain, right? So one of the most common things, correlations for patellar tendonitis, was a athlete that had bad ankle sprains and then had to constantly get really bracing athletic tape for their ankles all the time, because they would have to get all that aggressive taping to stabilize the ankle. Now that's too not mobile enough. Where does the stress translate? So the knee would start developing symptoms because the ankle had issues. Thus, if the ankle could be made more symmetrical in its abilities, whether it be it needs stability or it needs mobility. And with cases like an ankle sprain, typically over here is too loose, and over here is way too short. So if I just identify that and try to balance it out, coupled with them doing some balancing exercises, if this could just do 10% better, you'd be amazed at what the accrued benefit could be here. And that's the biggest thing I want to say, especially with the foot, is if we really make sure the toes and the ankle function better, that means every single step you take is a little bit less stress on the knee, the hip, and the spine. If that foot is operating more efficiently, the whole chain is given less stress, and it's like getting free energy for every little bit of effort is finally reduced.
Can you explain how exactly the ankle correlates to the patellar tendonitis? Like what muscles?
We'll go to the muscles. What it really is about is jointed structures. That joint, if it's made too unstable or too stable, if it's not kind of at the right middle ground of joint play, then the change of adaptation is going to have to occur somewhere up the chain. So if the ankle is offset, let's be more precise, if the ankle is crooked, the body's not going to really usually adjust for you to walk around with that foot inverted without making flat contact. So you'll change how you orient your hip and your knee to make contact. But now the knee isn't in correct orientation. The femur isn't lined up on the tibia, and the patella isn't lined up in such a way those quadriceps muscles are going to start pulling it in odd directions. Really, the easier way to think is when it's a closed chain system, which is going to always be foot to skull. When one is offset, it's going to cause a distortion of stress in the other. The other visual thing I've always thought about is if you make one leg of a table lower, the two on either side stay flush. It's the one opposite on the other side that now has the wobble with it, right? And you could stabilize either one of those. You could put a stand underneath. Now, it might be a crooked table, but at least it's stable. But it's just that the stress is going to translate. And sometimes people are unique enough where it skips a spot and goes right to the hip. It's like it started in the ankle and the foot, and their knee is actually fine because their knee's just off, but then they start getting hip and low back issues. But you also can't have an issue here without it distorting everything down the chain. The low back down in particular, you will have distortions that translate all the way down to the foot. And if that is there long enough, then you have to address all of it. And it ends up sometimes being easier to go the opposite direction of the effects of the symptoms. Like it started in the low back and caused distortion all the way down to the foot. It's like, well, okay, the foot was the last one to have problems. Let's clean that up. Then we'll clean up the knee. Then we'll clean up the hip. And now finally we can get to the low back, and there's less mess and noise in the way of all of that. That's what like principles like Rolfing actually use, even though it was mostly developed for teaching purposes. But they'll spend whole sessions on the foot and the lower leg, like a whole hour here, and then a whole hour here, and then a whole hour here. The construct being that you're working your way up these kinetic chains. Now, as a massage therapist, though, remember we're doing this. So working on fellow massage therapists, you need to think in the same way, right? All right. Knees and elbows. Here, the functions are actually much simpler. There is some rotation play at the knee. The elbow has some interesting elements with how that olecranon comes in. One of the worst injuries I ever saw was a really bad break of the elbow. So try to be nice to yours and all that. But here, really there's not anything too advanced. We can go over the muscle names, but the ways of interfacing with this are just going to be, again, kind of just being thorough. As far as the arm is concerned, the hack for the muscles is everything from the anterior shoulder, aside from deltoid. Take deltoid off of this. Everything else has BRACH in it. I know I've had to say that, but it's a brachy something. There's from the coracoid process of the scapula down onto the humerus, coracobrachialis, lead to the brachial plexus, which are the nerves and blood vessels that come through. But coracoid process, brachy. So coracoid, if I know what the coracoid process is, which is that weird little hooky projection on the anterior side of the scapula, that this muscle and pec minor are attached to. Now I usually know on a test that they're probably talking about coracobrachialis or pec minor. But coracobrachialis, bicep brachii, which has two heads, long head and a short head. Brachialis, which is just now only bicep brachialis works at the shoulder and the elbow. Then brachialis, and then brachioradialis. Brachioradialis, you know it's about elbow function because it has brachii something in it, but it comes down onto the radius. So it's that muscle that you can find here. But brachii something, B-R-A-C-H, it's there. And it's just deciding which one. Being there, then you just have to think more precisely. How do you get on this stuff? This medial line is where you have to be careful. The triceps are the triceps. I'm not going to bother going too much into those. The thing to remember about the triceps is the long head. Look where that goes. Posterior armpit, all the way up onto the scapula. All right? So triceps, the long head of the triceps and bicep brachii, they act at the shoulder joint as well as at the elbow joint. Usually we're working closer to the shoulder joint. This is why I stress so much working with the arm off the side of the table. If it's like this, those tubes are just aimed right up at you, and it's easy to inadvertently end up on those. Pulling the tricep, pulling that line apart to make space for those tubes can be important, but really all that needs to be done there is, just don't do it. If we move the arm off to the side and stand here, we're in a perfect orientation to create those bending forces like this, right? Then the next part would be, how can I get more targeted on it? Which will be working more, thinking about those three. So there's kind of a central one, the short head, then a lateral one, and a medial one. The medial one is the long head. If I hold the elbow with one hand and use my forearm, one forearm, I can get the central line, and then that more lateral line. That doesn't quite work. I think it'd be, yeah, that's lateral. If I switch, now I can work more on that medial one. Being cautious to not come up onto those, but you'd have to try pretty hard in this orientation. This is the one where you could accidentally get it. Right there though, coming all the way up into pretty much the posterior armpit. I know that I've shown some of this in the demos, but looking at the anatomy gives you a clear reason as to why. And what I use in order to confirm that I'm in the right places is elbow action, because I'll have that tricep kick on, and then I can start finding this crazy intersection up here where teres major and minor, where the adductor attachment comes over. It's a whole messy spot back here. I use working on the elbow as a guide to eventually get me somewhere that's usually really important for the shoulder. So I can start here, and person could, for all of those, be doing elbow actions. It's a nice thing, this is pretty simplistic, just here or here, be thorough, you got it. The next part of the triceps is working your way up, and this is the best orientation because see how I can come right in line with where that crazy intersection is. And this is like, for example, where my symptoms hide. My shoulder issues are predominantly because this is all stuck together. So naturally, I'm more like, I think it's really important.
But for you, it's more structural?
It's those muscles got so strong, but they got glued together because I live like this, right? So those muscles were learning to engage isometrically too much, right? So you have to be a little careful. That's why my exercises tend to be a lot of lateral and over my head actions to counterbalance that. It's like saying to a golfer, swing your club the opposite way some, and maybe that'll help you balance your body out. So if I'm always here, then I need to think, making sure I do that too. That's the other longevity one. Reach over your head. Doesn't even have to be with weights, just stuff like this. All right, once I'm here though, if I want to be more precise and figure out exactly where I want to be, and I want to get all of those layers unstuck, and this is a crazy intersection. Again, listing them out. We have the triceps attachment. We have both teres minor, which is part of the rotator cuff, but then also teres major, which is not, but both of which attach under the scapula. So their scapulas are winged out weird and stuff like that. Adductors, the meat of adductors is more here, but that attachment's pretty big and bulky too. So if we can just get ourselves really efficiently set here, we're affecting all of that. Now, I have a person extend their elbow, they gotta go to full max extension. That will kick on real strong, and then you'll feel exactly where you should be. If you can precisely get your pressure on that aspect of tricep, you're pretty much right there perfectly at the intersection site. So then the actions I have a person do is it can be, all right, hold that at full extension. Okay, slowly let it go. If I have to, I could have them even like kind of curl and flex their biceps. But really most important, full extension, slowly let it go. Then as I hold this, and I'll say, now I'm gonna have you, I can passively do some of this too. I'm gonna have you turn your whole arm over this way. There's be external rotation and supination. Now that slides all that stuff underneath my forearm. Now go the other way. Pronation and internal rotation. Now that's going to it's going to aim me right more up on Terry's major and adductor attachment. I get to just hold my position and have them do those rotations. So I usually coupled it, have a person do this, roll, roll, okay, relax. Again, roll, roll, relax. Done.
If a client had an issue, where would the issue radiate? I mean, what would they say when they came in? So
The symptoms here, most commonly, people will either point. There's a point test, and it could be a rotator cuff something, but remember that subscapularis and infraspinatus have a shared tendon that wraps right around here. So lots of time people will point, and you'll see like in trigger point systems, to be like it's subscap. It's usually both of those are too tight, and they're kind of, now there are the tendinous aspects across the front, but just in general, most people will have something that manifests on the front. There are the rarer-ish people like me where it is back here. I do feel it there. It's a scapular nerve impingement instead of a brachial plexus impingement. The brachial plexus impingement is much more common. Or it's shoulder arthritis, or it's an AC joint thing. Old rotator cuff tear. That's going to be one of the most common ones you'll find. Old rotator cuff tear and or arthritis. Both of which you need to get all of it, but this is the under-addressed one because it's kind of hard to get to. And it's more awkward to get to in side lying because you have a person's arm up like this and you're like this. And a person with bad shoulders getting out into abduction will be the most uncomfortable action. So sideline here is an option, but it ended up sometimes feeling inefficient for me. What's nice about this one is you can also soft fist.
So can you get the teres minor and major in that position? Is that what you're pressing on there, or what about?
That's them right there.
That's what okay.
That's teres minor, that's teres major.
So when you're putting pressure on, you're not like in the armpit, you're on the arm.
Yeah, more posterior.
Okay.
That's where this buildup, that's where it kind of goes into. You can't be going into this stuff like too blind related to the anatomy. You have to have a stronger sense of how these things are set on these bony structures. You should feel that scapula right by you. That's why I say do the muscle action as a muscle test to confirm if you're on triceps to start. That means you're at least posterior enough where you're not so medial that you could be on something dangerous. So you want to start here on tricep, and then you could get a bit more precise. But the easiest action by far is to just stay there and have a person do little rotations underneath of you. And like anything, when you're in an area that is potentially somewhere where you should be cautious, confirm with a client that, hey, as we do these actions, I don't want this to ever feel nervy or like we're too much on a bone. I need you to tell me. Same thing when we get to the suboccipitals. I always do a pressure check and try to confirm like, hey, you need to let me know we're in a sensitive area. So the pressure has to be just right, not too much, not too little. At no time should it feel like I'm cutting off blood, air, or causing an electrical zap around your body, right? You can put a little humor to it, but in these sensitive areas where it's more therapeutic, get them verbally engaged with it, especially if they're already going to be doing actions anyway. Might as well clarify, hey, remember, nothing nervy, nothing that feels like it cuts off circulation.
But other than that, you shouldn't, like, there's nothing you should really pay attention for. Like, if it's not causing the client pain, it's fine.
Yeah. Yep. And it should feel like that good, like intensity. The only challenges I've had here have been if the edge of your table is too sharp. Because then as I'm working, I'm pushing them into the edge of the table. And that can be uncomfortable. But that's just a really important one. On the flip side now, and you can find ways to do that in sideline. It's just that I'm too used to people with shoulder-related issues. The movement that gets restricted the most, regardless of the source of the problem, nerve impingement, arthritis, anything, is abduction. So if they can at least get their arm off the side of the table, helps you. a lot. A sideline, you could find a way to kind of leave their arm there and work here a little bit, but it's not going to be as good. So if you can get their arm up high enough and come in there, go for it. That one's not too hard. On the flip side of that, nothing's going to change a whole lot. You've seen enough related to the pecs, right? That ends up being the important one. So as long as I can get my forearm set right on top of that intersection. I want to get pecs too. Like you should work on pecs like along the sternum line and pull them away from that. That's important. But the key intersection here on the anterior chest, just like this posterior intersection, is going to be where pec minor, pec major, coracobrachialis, and deltoid all overlap. That's going to be just that line right there. You'll never feel that coracoid process. At least it'd be pretty odd if you did. The initial contact is why I have you kind of start out like that, so that your forearm is more, your elbow and your forearm are more lateral. But the actions then can be that pulling the arm, bending the elbow, arm back and forth. But we can go a step further, straighten the arm out. I grab underneath the elbow and then just roll or lift the arm up like this. That can be a pretty aggressive pin and stretch. If you start them like this, grab, so I'm holding my forearm here, and then reach around like this and pull their elbow up, their arm up toward me into abduction. Pin, stretch. Doesn't take much of a stretch. I don't have to take it to end range to really get an effect there, if that's truly short and tight. So it's either compress, rotations, compress, abduction, adduction. The most aggressive versions of this would be coming around to the other side and trying to lift pec or get really on top of pec minor. The other thing about working in supine with this is you can get on this line there. You just have to be really careful. We're not teaching subscap release today, but right here, that's subscap. That's teres. That's where latissimus dorsi and triceps would be. If I have a person laying supine, I can bring their arm up and come in like that. You just can't be in the armpit. You have to make sure, usually it feels like this part of my hand is touching the table. That's what keeps me, this is all too rigid, but keeps me from being too high. Then I'll adjust and get a little bit higher. And then doing the muscle actions. In this case, I have them, usually I'm holding them like this. I'll say like this is the action I want you to push down into me. Or I'll put a towel here with a sheet there. Here, say, all right, push into me. All right, push out and away. Push into me. Push out and away. Adduction, abduction, while compressing that unified, crazy intersection point. If there's really bad issues there, do a little bit of both, not just one of a lot, or a lot of one. There we go. So you get a little bit in prone, get a little bit in sideline, get a little bit in supine. All right, let me quickly get us through the hip. Thankfully, I feel confident that you were lambasted with how to work on the glutes and deeper lateral hip rotators and hip flexors. So good to start that shouldn't feel too problematic. Now, as I was talking about bicep brachii and the triceps, the correlations occur here with the hamstrings. Hamstrings correlated with the biceps, mostly related to the knee, because everything flips up here. Up here, the posterior side of the hip is about extension. The posterior knee is about flexion. Yeah. You flip it over. The arms are easier. All flexion. all extension. It'd be easier if we were ostriches and our knees were on backwards, then it would all make sense. But the knee is on basically backwards is a way to kind of rationalize that. So the hamstrings are involved with hip extension and knee flexion. Rectus femoris, not the other quads, all the hamstrings do all of those. Rectus femoris, the top quad, and sartorius are involved with actions at the hip and the knee. This is a whole crazy thing that I'll come back to, but the big intersection up here related to hip flexion. Back here, there isn't so much an intersection as there is just being able to get to this stuff, which is really the proximal attachments of the hamstrings up on the ischium tuberosity. So the ischial tuberosity, that little thing that you actually sit on, where you see those holes, that's where the hamstrings go, very medial. Meaning in prone, it's pretty easy to get the stuff closer to the knee. And get the central line and the lateral aspect of it. It's still not the most efficient to me, but trying to get up here gets real inefficient. So in prone, I only worry about that distal half. Then sideline, now we can get to the rest of it. But sideline lends itself better in general. In prone, I tend to at least get this lateral portion to kind of bend the hamstrings away from my T-band. But then that's all I worry about. I get the lateral aspect of hamstrings, I get the lateral aspect of gastroc and soleus. And then I turn people on their sides, and then I can orient the leg in such a way where, and bend my elbow more acutely, and come in on that central line, and come in along this medial line between hamstrings and adductors, which that's a real messy place. It doesn't get appropriately considered. The connection point here is that adductor magnus is a synergist with hip extension. See how it attaches more posteriorly? The rest of the adductors attach more anteriorly, and they're synergists for hip flexion. So confusion, confusion, confusion. Might as well try to separate all these elements so that they're ideally less confused. So the line between the hamstrings, trying to separate that. The line between hamstrings and adductors, trying to separate that. If I can get right down the middle, down the central-ish line of adductors, give them some space. But in this case, I'm thinking about adductor magnus versus the other four. Just trying to get them out of the way and give just adductor magnus some attention. And it's correlated with these anyway, so there you go. Same thing with gastroc. That line of gastroc, trying to separate gastroc from soleus. Now we'd already talked about separating everything from the deeper layer. Up here, for hamstrings in particular though, this is where we can incorporate knee flexion and extension much more easily. I can stand like this, grab here and pull toward me. I could bend the knee so it's like this and come in like that. And every time I move forward, the knee will be bending. It was seen in some videos somewhere, Sandy and I doing it. I got that from me mother. But knee bent, should have a sanitary barrier, a sheet, towel. Then as you massage, that knee is getting small flexions, extensions with your body movement. Or they could push into you, or I could create resistance into extension and flexion right here. So they can push into me for extension, push into this hand for flexion. But even the passive elements of all that, it just does more. And it's really efficient. But it's just, that's all it comes down to. Sometimes the sheet gets in the way. So you climb up, you come up here, you gotta move the sheet down so it's not ruffled too much and go directly over top of it. The goal being to be there. Orient your hand correctly. Don't have your hand be up here. That's why my elbow is like this. But if I do that, can't miss it. The adductors in supine, if you externally rotate, and we can bend them the other way. If we do that in sideline, they got bent that way, and adductor magnus got more attention. If I externally rotate the leg in supine and come at them in this orientation, I'll get that more anterior forward and I'll bend them that way and separate them from. Hamstrings got separated from IT band, hamstrings got separated from adductors. Turn it, quads get separated from IT band. That one should be easy for you to find and do. But then there's also separating quads from adductors. And then everybody there is happier. In doing that thoroughly, usually cleans up all the knee issues. The only other thing to return to there is the firing pattern stuff. Sometimes you have to inhibit gastroc and have them activate hamstrings to get that functioning more efficiently. Here, inhibit vastus lateralis while they do knee extensions to get vastus medialis more dominant. There's plenty of videos on the firing pattern stuff. Up here, the last bit, is one thing I want to highlight is how crazy this split is, okay? We think of the quadriceps as like the predominant anterior upper leg muscles, right? But up here, related to it's easy here. It's the four quads, and they all act at the knee and extension. And you heard the firing pattern one, the most dominant should be vastus medialis because look at where the belly of its muscle is. It's closer to the knee. Now, up here though, is where we have a cool like three-pronged foot where rectus femoris, the top quad, starts real central. They meet really close, but pretty much at the anterior superior iliac spine. Right there. So if you can find that, you're going to find all of these, is the hack. Find that, be here, and you can be more medial, more central, more lateral. Let me see a theme. Find these intersections and be central, lateral, and medial. So pretty much on top of it, side to side. And you'll get all of it because they are all so close to each other there. Now, the most superficial ones are actually sartorius and tensor fasciae lata. So tensor fasciae lata, that's what you need if you're going to get any kind of an effect on IT band. It's also an internal hip rotator, so it's essential for hip function. Sartorius, this is the weird thing. All of these are synergists for hip flexion. Makes sense, right? This one controls the tension of IT bands, so more about stability, but also internal hip rotation. Guess what sartorius does for hip rotation? External rotation. So synergists for flexion, antagonists for rotation. Rectus femoris just does flexion and then extension of the knee. However, here's the weird thing. Now you have this bracing the lateral side of the knee, so lateral knee issues. Could this be a contributor? Medial knee issues. This and adductors. Could this be an issue? But this isn't usually the place where you want to work. This is what gets inflamed, and it's usually mostly due to this being way too short. Everybody's stuck in a seated position. So where's the tension? Where's the actual short stuff, and then where's the long stuff? The long stuff is here at the knee, and it's getting more friction. It gets angry. We need to reduce the tension here, and now that patellar tendon and the lateral and medial stuff has more breathing room. That's why it's going to be a lot of saying, yes, knee stuff, be thorough, go after the ankle, and especially the hip, and that'll probably be the rest of it, because the same thing with the hamstrings. Fix that, free this up, there you go for stuff related to the knee. If you don't pay attention to the hip, that's probably where the problem is coming from. Back to this, all flexors, internal rotator for tensor fasciae lata, external rotator for sartorius. Rectus femoris, a knee extensor. But sartorius, the way it does that crazy hook, when it contracts at the knee, it's a knee flexor. So, synergists up here, antagonists down here. Synergists up here for flexion, antagonists for rotation. It's a messy place. So squash it and do what? All the motions. Squash it, have them do knee movements, extension and flexion. That'll create a conversation between rectus femoris and sartorius. Like, look, up here, you guys are only thinking about the hip. So at the knee, learn to be independent. So you're inhibiting here and having them learn how to function separately at the knee again. So it's really easy. Compression, then straighten the knee, push down to the table. See what happens. If that makes the symptom more, if you feel something activate more. Coming a little bit more lateral onto tensor fasciae lata, that's usually a real trigger point laden spot. But here, then it's just rotations. It can be hip flexion, but then it's roll in, roll out, roll in, roll out. Now we're creating a conversation related to getting these muscles to be individuals relative to rotation. So rarely do I push here and have a person actually do hip flexion and extension. I tend to push here and have them do knee actions and hip rotations. And that cleans it up. The most aggressive way to work on it would be you have to make sure a person's crooked enough so that their hip joint isn't off like this. They can't be starfished on the table. You have to make them lay where they're outright, fully on an angle. Get the knee off the edge so that the leg can drop into flexion. Then you can come down on these, and then you can incorporate all those hip actions really easily. The really big added value here in this position, and this one did help, I mean a ton. As long as a person can get into that orientation comfortably, that ended up being the best way I could get them to start engaging gluteus maximus more effectively. So hip flexors versus hip extensors, this is the most important one. We talked about some internal rotators. Here's the rest of those external rotators. I'm confident you guys can find those. There you just have to be sure you're really working your way around that greater trochanter. And you gotta just, sometimes I pick 4 if not 6 spots for all 6 of them. So piriformis, there's 6 total, piriformis, then 2 gemelli, or gemelli, I start with a G. Gemellus superior, gemellus inferior. Guess which one's above and which one's below. Then obturator and obturator. Obturator internus, obturator externus. And then the one I could never remember, and not being able to remember it for a few years finally got me to remember it. And that's the lowest one, this one. So piriformis, gemelli, gemellus, and obturators. Quadratus femoris. I don't have a good remembering hack for that. It's shaped like a, square, but under the femur. But that one, but look how low it is. So that just means in this orientation, up here, the gluteus maximus, and then as I work my way lower, now I'm thinking piriformis, rotations. Down, the other 4 rotations. To be on quadratus femoris, I gotta be really low. I gotta be standing where the greater trochanter is actually either right in line with my elbow or a little bit above me because of how low that is. And I am convinced with Sandy that although piriformis is the most common related muscle to sciatic nerve impingement if it's muscle related. This one I think also is a big problem because I think it's the one that you're sitting on. So getting that freed up. It's not necessarily about releasing it, it's about compression and creating friction to create space for that. Yeah, there you go. Oh, the last part. Here though, and when we talk about low back stuff, it's forever gonna be, just like how with ankle stability, super important. Here related to the core and the hip and the low back, it's your glutes and your obliques. Now, plenty of people have heard how important the obliques are, but the glutes, finding effective ways to engage those and exercise those, it is problematic. Like at the peak of your squats, you gotta like really squeeze and go to extensions. Stair steppers and things like that actually engage it more because it forces you into like more of a hyperextension phase. And that's the key with gluteus maximus, is that the fibers fire more and do hyperextension. That's why the runners have such incredible glutes, because they're really going into hyperextension. They're engaging those fibers more. And why a person can function pretty good with smaller gaits, and then they end up with more like a flat butt, but they're still functioning okay. An individual that doesn't have a very big gait, and maybe you don't need it, will end up being more hamstring dominant. And it's functional. You can function just fine being pretty much hamstring dominant, but you'll always have an easier time in life if your glutes can come in and help out more. Thus, this orientation, where when a person's laying here, don't just bring the leg over like that, okay? It's not like it's uncomfortable for me, but it's not gonna put you in an orientation that meshes with their gait, right? Nobody's walking around like a starfish crab. So they have to do this horrifically difficult thing and lay on an ankle, okay? Once they're there, now your assessment already tells you my quads are a bit tight because my knee is stuck in extension. If I do this, there's plenty of resistance. Now, you apply your compressions here, and we could have a person do all these knee actions while holding these compressions in a variety of positions: central, medial, lateral. I could passively reach as the therapist, grab onto the tibia and rotate. Could have them do that against resistance, right? So I'm standing there. But here's the kicker, kind of the kicker, the reverse kicker, the donkey kicker, is since the hip is set a little bit into hyperextension, it makes it much easier for a person to isolate their glutes. And you have the hamstring shortened. So having a person do this tends to make it easier for them to isolate gluteus maximus and not co-contract their low back muscles, their lumbar erector spinae, and they'll still get their hamstrings ticked up. You can find your glutes much easier here. So I've used this because I have SI joint issues. And I do this on either side, and that's how I'll get it to feel like it sets. But can you imagine, these are too short. This is the exaggerated pattern of distortion. I need to reduce the tension here and increase the tension here. So compression, kick your glutes on. Compression, kick the glutes on. That was for low back and hip stuff, probably one of the most essential treatments I did consistently with people. That along with psoas. The only thing that you get limited with there is if they can't get their hip into that position. And if that's so, you leave the bolster under and you do all the other ones that I talked about, where you can do the compressions along that line. Compression, there's all the passive movements we can do here, or we could have them do them active. But the really big winner, leg off the table. But don't be lazy. Make the person be crooked. That's the only way to do it right. There's the limbs. We did it.